Yes, yes, we can see you.
All right, wonderful.
Well.
Greetings to everyone. My warm welcome and warm greetings to all the viewers, the entire audience all over the world. Guys, thank you for inviting me for this multinational talk. This topic is of extreme importance, I believe. And this topic to me is very dear to my heart because since 25 years when I started my medical career, somehow regenerative medicine and possibility of disease reversal and tissue remodeling has been always fascinating me since I was a medical student and throughout all the years of my career, and I've been working in many countries and different continents. And this topic of stem cells particularly interests me not only as a scientist, but of course as a medical practitioner, as just a doctor, but to a large extent as an enthusiast, as just an individual and a potential patient. Because I see a great opportunity for the mankind and of course for just my family members, possibly for me, myself in future, to be able to extend the quality, improve the quality of my life and extend the lifespan to a certain reasonable extent. And I've always been a biohacker, okay? So I'm doing a lot of experiments on myself and I openly disclose that. And cell therapy and stem cells and the entire biological and regenerative medicine has been an essential part of what I've been doing for all of these years. And despite the fact that perhaps there's hardly a person in this entire world who have not heard anything about stem cells, the topic of stem cells is being quite misunderstood. And although there's a large number of extremely well-educated practitioners and scientists, but over years of me meeting people all over the world, I came to conclusion that as well as people are well-educated, there are a lot of people who are miseducated about stem cells and regenerative medicine. And as Professor Dennis has explained, it also leaves a tremendous impact on the pace at which regulatory authorities all over the world are not only approving this as a treatment modality, but even looking into this. So I believe that the attention that has been given to stem cells and regenerative medicine is insufficient and inadequate, to say the least. Before I continue, I'm trying to change the, okay. Before I continue my presentation, I would like to give a disclaimer that there is no conflict of interest. I'm doing this talk, I'm participating in this talk on my free time. It's a beautiful weekend out there. I have absolutely no commercial, no financial gain, no benefit out of this presentation. And everything that I'm going to talk about is a result of more than 2 decades of my personal research work, my education, my professional activity, as well as my personal experience in this field, believe it or not, as a recipient of this therapy and as a patient as well. So I'm a medical doctor myself, and you can see some pictures back when I was actively involved in my medical and surgical career. And I've done the postgraduate training in surgical endoscopy and the minimally invasive surgery. And about 15 years ago, I've done the Ph.D. in Institute of Emergency and Reconstructive Surgery. So as you see, I've always had that interest towards the disease reversal and the tissue engineering and regenerative medicine. And I'm also a speaker for the RADFest, and I'm a faculty member and educator for the American Academy of Anti-Aging and for the American Association of Stem Cell Physicians. I'm a group medical director and medical board advisory board chief for the European Wellness Group, and I'm also a member of various international societies such as the Society of Cell and Gene Therapy or the Society of Integrative Medicine. and so on. So I have quite enough credentials to talk about it and about this topic. So what I would like to touch, and I'm deeply grateful to Professor Dennis, who brilliantly described the science behind the stem cells and how it works, and there's practically nothing else to be added to that. So I would like to look at this topic from a point of view of both the medical practitioner. What can the medical practitioner, how can they use this treatment modality, and where, at what place, at what moment of the entire treatment protocol can they place the stem cells? Because in spite of this topic being discussed quite vigorously, but there's practically no guidelines given so far, and there is no proper understanding of both medical practitioners on one side and regulatory authorities on the other side, and the patients, and at what point, how exactly, what sort of cell therapy protocol should be placed to achieve the maximum benefit. So for us to understand the importance and why should we even talk about stem cells and regenerative medicine, just look at this slide. And this data was published in 2015 by United Nations, the Department of Economic and Social Affairs, and the Population Division. And they have projected that the population, the amount of people who are 85 years old and above, I emphasize it's not 65, 85 years old and above, throughout 2015 to 2020 is going to triple. The amount of people who are older than 60 or 65 years old is going to quadruple or even probably increase by a large extent. And we, even without looking at these statistics, just look at yourself and look at your family members and look at the people whom you know, and probably you would be able to come to conclusion that medicine, conventional medicine, and the science, contemporary science, have definitely made us, and when I say us, I mean the entire civilization, the entire population, live longer, but obviously not living better. And even the current pandemic and the situation with COVID-19 is another proof for that. And we can see that even with this pandemic, there's a majority of patients, of individuals who have been severely affected by the disease are people either of the senior age or people who have some specific underlying chronic degenerative conditions or medical illnesses. And the least of those medical illnesses, which fall into the category of chronic age-related degenerative disorder, is extremely vast, and it is including all the illnesses that I have listed on this slide, but definitely not limited to that. So there are probably hundreds and thousands of diseases which are degenerative diseases by its nature. And when we talk about the degenerative diseases, we mean that, well, look at it this way. Every tissue, whatever tissue in our body it is, starting from the blood, which is a tissue, ending up with a bone, which is also a type of the tissue, in principle consists of the cellular component and the extracellular matrix. So throughout the process of aging and the development of age-related degenerative disease, there is a loss of the tissue component, of the cellular component, and there is a degradation of the extracellular matrix. And as long as we find effective solutions to improve the condition of both, you know, to revive the cellular component in the tissue and also to do something with the extracellular matrix to regenerate it, we will achieve the target of reversing or at least controlling, if not to say complete cure, for any age-related chronic degenerative disease. So a couple of years ago, this article came to my attention by Claudia Franceschi, which is called, it was published in the journal Frontiers of Medicine, and it's called The Continuum of Aging and Age-Related Diseases. Common mechanisms, but different rates. And why this article is so important, in my personal opinion, is that there are few vital conclusions that were made in this article. The number one conclusion is that aging as a biological process and the disease, a chronic age-related degenerative disease, they essentially share the same common mechanisms. So you can say that, in a way, aging itself can be considered as being a disease. And I hope that World Health Organization will include it, if they have not included it yet, into the list of the medical conditions. A second great conclusion, which was derived from this article, is that, imagine it this way. United Nations, and the statistics that I've shown you on the previous slide about the 85-year-old and above citizens tripling within the next 40 years, also tells us that if you take people who are 60 or 65 years old and above, 92 to 93% of them have at least one chronic degenerative disease. And about 65% of those patients have two or more chronic age-related degenerative diseases. If you will treat a specific disease in a person, you can actually succeed. It is possible to treat and cure one particular disease. And conventional medicine has greatly succeeded in that to a certain extent. However, those endeavors, they will sort of die in vain, because simply the person will die because of another disease. So the logical and rational conclusion that has to be made is that when you have a patient, an aging individual, and aging individual literally is every living human being, because we all age at a different pace, and some start younger, some start older. It depends on your genetic, epigenetic, and environmental factors. And sooner or later, we all develop certain age-related degenerative diseases or various forms of cancer. It's just the biological law. So if you want to achieve any feasible success in age reversal and control over the chronic diseases and improving the quality of life and extending the lifespan, you have to target all chronic diseases at once, immediately, in one go. And the best idea behind that, the best way to do that, is by targeting the aging as the process which actually shares the common mechanisms as the chronic disease does. About 10 years ago, a very reputable person, and whom I follow and I have a great respect to him, is Dr. Professor Aubrey de Grey, and also the number of other scientists, as the Tony Weiss-Corey, whom I quoted in this particular article. They have identified a specific drivers, or they call it the 7 pillars of aging, or the drivers of the chronic disease, and the same drivers are actually the drivers for the aging. So let's look at it. It's a disruption in metabolism. So any form of metabolic disruption, whether it's improper metabolism of the fatty acids, or for example, triglycerides or cholesterol, or it's the increased resistance to insulin, or less sensitivity to insulin, and further disruption in the metabolism of carbohydrates, that all essentially falls into this category of disruption of metabolism. Next thing, every age-related chronic degenerative disease is also associated with a macromolecular damage. Call it as you wish, the cross-linked molecules, whatever, or impaired formation, or defective macromolecules because of the genetic aberrations or mutation whatsoever. But it happens, and it's associated both with age and with all chronic age-related degenerative diseases. Epigenetic shift of course, you know, what our environment and the medications that we take and some accidents and incidents that happen in our life, they all create a tremendous impact. Not even to say that, according to the David Sinclair and the Harvard Research Group, it looks like the epigenetics are the epigenetic shift is the primary driver in the entire, this whole cascade of age-related disorders. Next thing, inflammation. And then Professor Dennis was talking about it. Low grade, we're not talking about the acute inflammation. We're not talking about acute tonsillitis or pneumonia or so on and so on. We're talking about low grade chronic inflammation that is ongoing for years or decades. It can be localized in some particular anatomical area, in some particular system, or it can be generalized. Next thing, impaired adaptation to stress. Organs and tissues and cells, and even on the subcellular level, as we age, as well as we develop age-related diseases, we lose our ability to react fast and adapt to the stressful environment. The proteostasis. Proteostasis is the ability of the cell, tissue, and the entire organism to utilize the byproducts of its metabolism. In other words, accumulation of all that the lysosomes, all the junk DNA, or the extra chromosomal complexes, and so on and so on. And last but not the least, because all these 7 drivers or 7 pillars of aging, they're absolutely equal in their importance. There is no factor which is more important and one which is less important. These are the concurrent 7 mechanisms that push us, put it this way, press the accelerator pedal on the highway of aging and on the highway towards developing chronic disease. So last but not the least is the stem cell and the regeneration, because intrinsically, biologically, we have the ability to replicate or propagate ourselves, as well as we have the ability to sort of preserve the energy and accumulate it and repair the damage, and that itself is the longevity or the survival mechanism. So regenerative medicine as a whole is addressing to these particular 7 mechanisms and these 7 pillars of aging, as well as some particular aspects or methods or modalities of regenerative medicine, while they may be addressing some of these components, but looks like that cell therapy and the stem cell therapy is also addressing to all these 7 drivers or pillars of aging unanimously. So we also can delay or reverse cellular aging, or at least the mammalian cell aging, by genetic, dietary, and pharmacological approach. And that is very important for a medical practitioner as well as for patient to understand that, first of all, it takes 2 hands to clap. Okay, so both have to put certain efforts. And also, there are no minor things. You know, there are no things in a treatment paradigm, in a successful treatment paradigm, which can be neglected. So the biological and the biotechnological approach, which is represented by cell therapy and the stem cells, is equally important, as well as the dietary and the pharmacological and genetic manipulation. I believe that something similar to this slide Professor Dennis has also shown. So there's always a correlation between the severity and the duration of injury or the disease, and to what degree the organ or tissue is malfunctioning. And the more it is in time and duration and in its severity, the more we have to resort to a biological or the biotechnological methods of tissue remodeling or tissue repair. And of course, we have the bioprinting, the 3D printing, the biomaterials, and so on, which has been tested, and gene therapy also has been tested to a certain extent. But those are not the things that readily available, put it this way. We will still need few decades before we will reach the bioreactors and artificial organs, organoids, and so on and so on. But what we have now, and what we have been having and researching actively, and also using this clinically and for the experimental and clinical purposes quite vastly for the past few decades, is the cell therapy, and the stem cells being one of its major components. So, of course, when we talk about medicine and the application of any treatment modality, we have to first of all talk about safety. So I'm not going to talk much about it. I've published an article last year about it's called the live cell therapy, its historical aspects and mechanism of action, and also its safety. It's in a journal of the Stem Cell Research and Therapeutic, so you can read the safety data about it. But generally, what I've concluded in that article is that those 7 pillars of aging, and let's just extrapolate them to these more concrete and easy understandable factors of aging, all of these, whether it's a direct stem cell exhaustion or the cellular senescence or the altered intercellular communication or the genomic instability, even the telomere attrition and shortening, even the epigenetic alterations, even the loss of proteostasis, even the dysregulation to the nutrient sensing, which in fact means the ability of the cells to recognize insulin, the presence or the activity of the receptors on the surface of the cellular membrane, all those things that deteriorate throughout the age and are associated essentially with literally every chronic degenerative disease. Stem cell therapy and stem cells and cell therapy are capable of stimulating or reversing these factors, and thus contributing to the entire improvement in clinical manifestations and well-being of the patient. Now, how it works. Now, from the point of view of a medical practitioner, there are few mechanisms of action of stem cells. We can divide them into 3 categories. Previously, for a very long duration of time, it was mostly 2 mechanisms of action, which were generally called as the homing effect and as the paracrine effect. So homing can be systemic homing or the distant homing, and it can be a local homing. Partially, it depends on the route of administration, which I'm going to talk about later, and I will show you slides how exactly and where exactly it has been used in my particular practice and in the group that I'm representing here. So, depending on the method of administration or the route of administration, or in science and medicine, we call it the delivery method. Those can be tremendously different. There's a vast variety of those methods. You can implant that intravenously, intramuscular, intraportal, intrahepatic, intrasplenic, perisplenic, perinephric, intrathecal, perarticular, intraarticular, and so on and so on and so on. There's multiple routes of implantation, and that is the subject for the actual medical guidelines in specific specialty, or the guidelines which are mostly regulating the treatment protocol of some specific disease. So after you implant cells, some of the cells, they, and depending on the method of implantation, they will retain locally in the area where you have implanted it. And some cells will sort of spread all over the body, and they will perform a systemic effect. That means the distant or the local home. After cells home, well, again, what's going to happen to them? And that depends on the recipient, that depends on the type of the stem cells, that depends on the disease as well. You know, it's a multiple factors that will decide the future fate of the cells, whether they will stay in the tissue, they will further proliferate, and they will differentiate into specific tissues, or they probably will be consumed by the immune cells or become a subject for phagocytosis. And there is no harm in that, because through that mechanism, what will be launched is the paracrine effect. So the paracrine effect, apart from the homing effect, is the second mechanism of action. So the paracrine effect is nothing else but the ability of the implanted cellular material to express a huge number and in a very large volume of various growth factors and various stimulatory molecules, which will perform a beneficial or a reparative effect to the tissues, whether it's by stimulating the angiogenesis, meaning the creation of new blood vessels in the tissue with a better blood supply, with a better supply of nutrients toward the tissues, or they will stimulate the stem cells, which are intrinsic stem cells, the dormant stem cells in the tissue. They will expand, increase their growth and stimulate their differentiation and proliferation. They will reduce the apoptosis, and in a way they will fight against the senescent cells, the zombie cells, which are neither dead nor alive in the tissue. They're not doing any good, but they just don't die. They've been immortalizing or nearly immortalizing themselves and just producing harmful toxic substances. So by killing those cells, getting rid of those cells, and overall by modulating the apoptosis, we can essentially reduce the fibrosis, and also via stimulation, the repair of the extracellular matrix. So for the past few years, apart from this homing and the paracrine effect, the immunological effect has been also outlined for the stem cells. And that is mostly via the massive anti-inflammatory effect. And as Professor Dennis has explained, there's a number of those molecules, those substances which are excreted by the stem cells, which reduce the inflammatory markers, they stimulate immune response, they sort of have the immunomodulatory function. And all these three mechanisms together, they provide that effective solution for those 7 factors of aging that we've been talking about. Now, which mechanism of action, whether it's an anti-inflammatory or the paracrine effect or the direct homing and cell replacement, is predominant in the stem cell effect, is still a question, and it tremendously depends on the circumstances on each particular case. And that explains why regenerative medicine and stem cells should be taken by a professional, as a biomedical practitioner, as a form of the precision and personalized medicine. So the factors that are expressed by stem cells, they reduce the fibrosis. You can see this entire fibrosis sort of group of factors. They reduce the apoptosis. They also stimulate other stem cell production, the intrinsic stem cell production. They also contain so-called brain-derived neurotrophic factor, and all which has been recognized for the past few years as the major lacking factor in those patients who develop neurodegenerative disorders like Parkinson's, Alzheimer's, and various forms of dementia, and so on and so on. They have generally the stimulatory and the proliferatory effect on the tissues, which is a great thing, because when your tissues are old and dying and you sort of throw in the growth factors, those molecules which will stimulate the tissue repair, it's literally, it's great and fantastic. Immunomodulation, chemoattraction, because as our cells age and our tissues age, the communication between the cells, the mechanisms through which cells communicate with each other, they also deteriorate. And please don't forget that on one hand we have these growth factors and so on and so on, but on the other hand we have cells, somatic cells in our body, that lose those receptors that are responsible for the sensitivity towards these molecules, they are restored to a certain extent as well. And last but not the least, antibacterial effect, anti-inflammatory, and the angiogenesis, which is a stimulation or formation of new blood vessels. So in a nutshell, what can you say? How does it act? Yeah, so I'm addressing now medical practitioners and patients, potential patients or individuals who are considering cell therapy as the treatment modality for them. What does it do in a very simple layman terms? First of all, it homes, it travels to where the cells are mostly needed. And those are the sites or the areas of the inflammation, of the hypoxia, of the tissue damage, and so on. So homing to the site where the repair should be performed. They regulate immune responses. They sort of modulated those responses which are overexpressed. Probably they will be suppressed to a certain extent or brought back into norm, and the inadequate responses are being stimulated and upregulated. Apart from restoring tissues, and I've been always telling that in my lectures and presentations that it's one thing that you can regenerate tissue, but there is no point in regenerative tissue if you do not restore the proper blood supply. In other words, revascularize those tissues. So the growth factors that will promote the formation of the new blood vessels, the regrowth of the blood vessels and the microcirculation in the tissues which have been restored is extremely important. Otherwise, all your endeavors will just die in vain. Ultimately, it will promote, reduce the premature cellular death, and will reduce the scarring of the tissues. In simple words, you will increase the amount of the active functional cells in the tissue, some specific organ, and you will also remodel, rebuild the extracellular matrix. You will reduce the scar or the fibrotic component in the tissue, and you will increase the functional component in that tissue. And what is achieved by that is repair and tissue regeneration, which in science we call as tissue remodeling. Now, next thing, what are the options that a practitioner and an individual have when in terms of the choice of the stem cells? What sort of cell therapy product can be chosen? You probably heard that you are aware that in many countries, regulatory authorities are more benevolent and more welcoming towards the autologous forms, various autologous forms of cell therapy, whether it's platelet-rich plasma or the stromal vascular fraction or autologous cell preparation, and so on and so on and so on. So I would like to draw everyone's attention to this article, which is not a new article. It's been published in 2007, and that shows that this fact has been known to the scientific and medical community for quite a long time. It's called the Aging Hematopoietic Stem Cells Decline in Function and Exhibit Epigenetic Regulation. In simpler words, what it means that when the donor is an old person, or when the donor is you yourself or your relative, even he is a complete match according to the HLA or any other antigenic systems or whatsoever, it does not mean that the transplantation of the cellular material from that old donor or aging donor will have any benefits towards you. A look at this slide, which is taken from the previous article that I have quoted here, and it's the immunohistochemistry, chemical staining. This red dots that you can see here, this red staining, is the staining of the cells for the antibodies of the so-called P65 protein, which is related to the specific P-selectin gene expression, which serves as a marker for the physiological biological stress, chronic inflammation, aging, and also cardiovascular diseases. So the authors of this article, they have compared young stem cells on the left, the slide B, and the old stem cells on the right, how much of these particular antibodies to this marker of physiological age, cardiovascular disease, inflammation they have inside. So the young stem cells have only 3%, you can see it here, versus the old stem cells have 71%. What it means to a person who receives this so-called old or aged or senescent cell material, it means that apart from probably some beneficial factors that might be transplanted or transmitted through this treatment modality, you're going to also throw into the fire of your own inflammation and your own aging, you're going to throw in a number of other detrimental factors. They're just going to make things even worse. What does it mean for a medical practitioner? It means for a medical practitioner that you will simply not get any beneficial effect in your patient. If you might just make things worse if you use some forms of autologous cell therapy or take it from a very old individual or whatsoever. It will definitely defeat the purpose of you doing the treatment. Now look at this article. It's a new article which is published about 3-4 years ago, but it's a meta-analysis. It's a review article talking about the senescence of the mesenchymal stem cells. There is still a part, despite the scientific discoveries and despite the rational argument, there is still a number of clinicians and scientists and all who still claim that the stem cell is just the stem cell. It has zero age, even it has been taken from a 90-year-old individual or something like that. Well, absolutely not. And this article is been debunking that fact, that myth, and explains and shows these micrographs. On the left, you have a culture of young cells. On the right, you have a culture of the old cells. And you can see that morphology of the cells is different. I will tell you more. The stem cells might even age inside the petri dish. If you will continue culturing and keeping those cells in the culture, in the laboratory conditions, and you will continue culturing them for many, many generations, which in science is called passages, you will ultimately will create a sort of a population of aging cells, which also have a lot of detrimental factors and the genetic junk material inside them. So it is very important, and thanks to the organizers to this talk, they've been absolutely great in their cell preparation. You know, they've been very attentive to how many passages of the cells have to go through in the culture in the lab before they're prepared as a final product. So the more, the worse, the less, the better. Now look at this, another proof of the stem cell aging, and it says that transplanting cells from old but not young donors cause physical dysfunction in all the recipients. Well, we even know the work which is done by Professor Tony Weisskori on the GDF, the growth differentiation factor 11, and how he has been able to reverse the cardiomyopathy, the senile cardiomyopathy in his laboratory animals. But what we see from here, that when you use the old cell material, you actually you can potentiate or sort of worsen this effect on the age via the various stimulating via various mitochondrial DNA mutation and the accumulation of the mutations. The cells can accumulate that karyotypic aberrations. They have a shorter telomeres. They have tremendous horrible epigenetic modifications, overexpressed markers of systemic inflammation and senescence. So this all is indicating that the cells, it is very important, the donor from where you are taking these cells. Yeah, it is very, very important. So it has to be an absolutely healthy living being with a proper track even throughout the generations, because such thing as an epigenetic factor is also very important. So when you have somebody with either in a control environment or who is properly checked and it's a healthy individual, whatever he or she or it is, and there are no genetic alterations, well, that will ensure that the cellular material that is prepared from that donor will have the maximum efficacy and the minimum risks or possible side effects. Next thing, it is also very important to understand that a medical practitioner and a patient also, they should understand that stem cells, as everything in medicine, has to be placed in time properly. There should be a proper preparation or some phases of the treatment beforehand, and there has to be a logical sequence of treatments and the follow-up after the main stem cell treatment is done. For this matter of fact, I'm a great fan also of the work of Professor Mark David Noble. He's one of the first people in the world who was the co-discoverer. He co-discovered when he was in UK, still the so-called the precursor stem cells, which are more lineage restricted cells, and Professor Dennis was also talking about it. Yeah, so it's very important to understand that we have a large variety, huge variety of different cell therapy preparations, and we have different types of the stem cells, and also a proper understanding of the scientific background, the fundamental science behind the stem cells and cell therapy on one hand, and the proper understanding of the pathological or pathophysiological and biological processes which are ongoing in a particular individual who is your patient, or those patients who are watching us now. Those are two pillars on which the success of the entire treatment depends on. So we have to remember that depending on which organ or tissue we're attempting to regenerate, and we might use different treatment modalities at a different time, okay, and there's nothing wrong in that. Also, we have to understand that I want to share something with you. You know, through all my years, going all over the world, you know, and meeting so many people, patients and doctors, you know, I hear all these stories, which actually it frightens me, to be honest. When patients come to some facility and there is no proper preparation, there's no proper outlining of indications, contraindication, there's no proper diagnosis. So it means neither patient nor, what is most terrifying, the practitioner who is offering some kind of treatment have a slightest understanding of what is going on with the patient. And the patient have just been injected or implanted or whatever, some cellular material, stem cells or whatsoever, without a clue, literally, and after that they've been just pushed out and okay, go home, you know, and things like that. Well, sort of like a shop kind of mentality. Well, it's absolutely, it's disastrous, I would like to say. You know, it shouldn't be done like that. When you treat a person, whether it's yourself or when you're working on yourself or biohacking yourself, as I do, for example, you have to make sure that you follow all the steps of the treatment. You start with a proper lifestyle, you trigger specific longevity genes, upregulate genes which are responsible for your survival, for the proper metabolism, and downregulate genes which may stimulate the tumor growth, you know, and so on and so on and so on. So all these things that I put in this slide, you know, it's very important to follow these steps and also correctly place various types of cell therapy in the treatment protocol. So we also know now that different cell therapy preparations, they might have slightly a different effect. They might have different emphasis. So some are good for something, some are better for something else, you know. So we are not using the embryonic stem cells anymore. It's long gone in history, probably like from 1980s or 90s. We know that there's probably no application for that. We're quite far from the induced pluripotent stem cells. To be honest, to my knowledge, only this or last year was the first clinical trial launched in Japan on the induced pluripotent stem cells. So what we have now, and apart from the autologous cell therapy that I've mentioned already, is the allogeneic cell therapy, and you need to make sure that you have it from the reputable source and all. And we have certain progenitor cells which are artificially created or procured from other species whatsoever, from the knockout gene animals. It depends, you know, from the SPF colonies, and also those are specific lineage restricted treatment modalities which can be used for and are used for a specific disease. Yeah, but when it's coming to the MSCs, most of all, it's a massive immunomodulatory and anti-inflammatory effect, which is clinically quite obvious and visible within the first hours or days. You know, I can tell you for myself, you know, as a person who have myself, I've received few types of the cell therapy, including the MSCs, you know, so I know the effect, I know how the responses work, you know. So you have the immediate effects and you have the long-term or the prolonged effect. So the immediate effect is just a massive anti-inflammatory effect. You generally feel great, better. Okay, and after that, and it takes time, and it's something, it exponentially grows in time. It's like a snowball. You have that stimulatory and sort of repair or the rejuvenation effect, which mostly involves multiple organs and tissues in your body, and that increases and improves due time. And I also talk a lot about combining different treatment methods and different modalities all at once. You know, it should be a multi-step, multimodal treatment strategy. I always call it the shotgun and the rifle. Or some doctors or speakers, they compare that to the Navy SEALs and specific army forces. You know, so when you have an enemy, and in this case, the enemy is the chronic inflammation, it's a tissue degeneration, it's overall loss of the communication interaction between cells, apoptosis, loss of regulation over the tissues, both genetic and epigenetic. You just need that sort of massive, the napalm kind of effect, and the MSCs are really fantastic for that. Okay, so it works very fast within the first 24 hours, and it's like they create the effect on that wasted land on all those hyper expressed inflammatory markers. And after that, you can continue other pharmaceutical approach or other types of cell therapy which are targeting specifically the disorder that is more prevalent in this particular patient. So I always been advocating this, not the monotherapeutic approach, although I'm quite against the polypragmacy. I don't like and I don't advocate prescription of multiple medications without a clue or different treatment modalities in the same time when you're not sure about how they work. So it all has to be properly placed, strategically placed in time, and you have to plan the treatment. You have to have a treatment plan for the patient, which will go at least for a few months, or better for a few years. So I've been always advocating the so-called programmatic approach in biological regenerative medicine, where you place various types of stem cells, either the hematopoietic, the bone marrow derived cells, when you know who is the donor and you can trace it back, you can trace the antigenicity, you can do all the sort of compatibility tests, you know, and whether the patient genetically, epigenetically, health-wise is suitable to be a donor. So done tremendously, and you can also combine that with other treatment modalities which will specifically target what we call an organ-specific or tissue-specific various other cell preparations. So I'm not going to talk or advocate any brands or whatsoever here. No. having a purely scientific discussion. Now, the multi-step treatment strategy, where exactly can it be used in practical medicine? Yeah. Let's divide it into two categories: the systemic stem cell application and the local topical, which will appear on the other side of the slide a bit later. Frailty syndrome. Probably this term is not really widely used that much by medical practitioners yet, because the frailty syndrome as a term has been coined less than 20 years ago. It's, if I'm not mistaken, Dr. Frey or Professor Frey, something like that. He has given this the description of this syndrome, frailty syndrome. But this is something tremendously important. And there are very simple tests on the frailty syndrome. You can every individual can even test yourself at home at any moment, whether you have any signs of frailty and all. But these are all the complex of pathological those sort of phenomena that is happening in your body that are associated with your anatomical decline, functional decline, and your cognitive decline. As a very simple example, for instance, a frailty syndrome is highly associated with a fall, increased frequency of fall, and with a hip fracture. So those are the things that are lethal for the senior or elder individuals. Frailty syndrome can be tremendously well treated with a stem cell approach, okay? And as long as the practitioner and patient, they do understand that there will be still, it's a fight against disease all the time, and you have to create a proper plan. You have to schedule the repeated stem cell treatment in time every 3 or 4 months or whatever it is, depending on the condition of patient. Next thing, COPD, chronic lung disease. Look at it this way: the intravenous administration, infusion of the mesenchymal stem cells, especially if you have an underlying COPD, which for sure will be associated with a degeneration of the lung tissue and with some known level of chronic inflammation, that will work as a perfect attractant to the infused stem cells. Some studies, some data shows that up to 99% of the cells which are implanted via the intravenous administration route will be sort of filtered through lungs. They can precipitate the lungs, and that explains why patients with COPD and various chronic obstructive disease of bronchial asthma, and even the patients with pulmonary fibrosis, primary pulmonary hypertension, and so on, they actually tremendously benefit from this treatment modality. Immunosenescence, immune system, although perceived as something not really tangible by many practitioners and patients as well, it's something that it's scattered all over the body, and a lot of people don't have a proper understanding of how the immune system works. So this, as a system, it also deteriorates, and we know it in science as immune senescence. These immunomodulatory effects of the cell therapy, they're tremendously beneficial in terms of reversing immune senescence. Neurodegenerative diseases, and these are not my words, but the words which are written by other researchers and practitioners in this field. It's beyond the shadow of the doubt is that cell therapy, stem cell treatment probably is the golden standard in treatment of the neurodegenerative diseases, whether it's Alzheimer's disease or it's a Parkinson, the ALS, Huntington, and so on and so on. Next, in muscular dystrophy and the sarcopenia, whether it is associated with the old age or whether it's associated just with the loss of the muscle tissue or with obesity, whatever it is. And by the way, it is also linked to the next point here, the metabolic syndrome. I sort of stopped using such terminology as diabetes type 2, or hyper or dyslipidemia, in my language, just because I call it the metabolic syndrome. If you understand this on that level, if you just take 2-3 steps back and you look at all the myriad of diseases of aging and metabolic disruption, diabetes type 2, all this dyslipidemia, fatty liver disease, and heart disease, and so on, this all is sort of indication that it's ongoing metabolic syndrome. And the premature menopause and andropause, which is happening at least 3 to 7% of the global male and female population reproductive age, that all can be stimulated with cell therapy. Chronic fatigue syndrome, adrenal distress syndrome, or adrenal fatigue syndrome as well. Cardiomyopathy, and various other chronic diseases of the old age. Apart from that, local stem cell application. What diseases can we treat when we implant stem cells precisely, particularly in that particular organ? Osteoarthritis, like the knee osteoarthritis and all, the data shows that about 93% efficacy of cell therapy-based treatment modalities of osteoarthritis. Spondylitis, erectile dysfunction, which is mainly via the so-called venous leakage syndrome. Vaginal rejuvenation, again, the neurodegenerative diseases treated via the intrathecal implantation, when you implant stem cells into the central nervous system via the guys calling me, I'm gonna finish soon. Various neuralgias, neuropathies used in hair restoration, hair growth, and also like skin disease, rheumatoid arthritis. Here, not only the MSCs are used for that, but also the stem cell culture and media. So these are the examples what you can treat. By direct injection in this area, you can actually help to reduce the inflammation in this area. You can target the faucet joints, you can reduce the inflammation in the roots of the nerve canals, and so on and so on. And there are specific treatment modalities how you first reduce the inflammation in the area of the joint, and then you implant cells there, and they will perform the cartilage repair. That's what's done. These some of the examples before and after the successful cartilage repair that we have done in our group. So I'm almost done, and before I'm done, ladies and gentlemen, I would like to share a bit of data on what's going on out there, and specifically about the COVID-19. So as you know, the COVID-19 is associated with a cytokine storm, which is nothing else but a hyperinflammatory reaction. It's an accumulation of huge amount of various inflammatory molecules which circulate through the patient bloodstream, and they are responsible for the respiratory failure in a way, and for the multi-organ failure and the kidney failure, and so on and so on. So there's been a clinical trial done, and this is a placebo-controlled study. They took a group of patients, a cohort of patients in a critical and severe stage of disease, and in various age, also including the senior individuals, like 65 years old, and they gave them MSCs, and also they took patients who randomized, randomly selected group of patients who received placebo. If you look at the rate of or the pace of recovery, it's practically within 3 to 4 days, some of them as fast within 2 days or 1 day, have been recovered and discharged. As well as in the group of patients who received placebo, there's one dead patient, one patient who was sort of like stable, and one patient whose condition worsened. It tells us, and of course looking at the whole pathogenesis of the disease, that is there a role, a place for the stem cells in the COVID-19 management? I believe that definitely there is. What we should do, we should just spend more attention to that, do more research, and look at this. The US National Library of Medicine and the website, the clinicaltrials.gov, they have published that there are ongoing, these rapidly going clinical trials on the use of various forms of MSCs and treatment of COVID-19, and all countries and in China as well. I'm going to finish. Yeah, if you want to know more, I've published some books, you know, that I've been writing for years and all. You can read more of this stuff about the stem cells and all. Thank you very much for watching. Thank you very much for inviting me. Everyone, please stay healthy, be safe, and be blessed. Thank you so much for your attention.